kind of a soft voice, so don't be afraid to raise your hand and ask me to speak up. Anyway, I run the dental health aid therapist educational program up in Alaska. I've also worked as a supervising dentist for dental therapists, and I've been involved with the development of the curriculum of our program.
Excuse me.
Know quite a bit about what's going on up there. I'm also the area dental director for the IHS, so I am in constant contact with all of the dental departments around the state and the tribal system. So, and you know, we have some really unique challenges up there in Alaska. Big, huge mountains, lots of water, no roads in a lot of our communities. So it's been a challenge to provide all kinds of services out in our state, and dental was no exception. And sometimes we hear that difference being used as a reason why, oh, it can work up there in Alaska, but that's really not the rest of the U.S. And some people don't even believe we're part of the U.S. So I am here to say we are U.S.
Same state here.
Yeah, that's right. Yeah, you guys are same issues. So, so we really aren't that different, though. What I like to say is that you know, if you can't get to a dental provider, it doesn't matter whether there's a mountain in the way or whether it's across town and you don't have a car, and you don't have anybody to watch your kids while you go. That still feels the same. It feels like you're not getting the services you need. And so I think we have a lot of good a good system that could be utilized in many parts of lower 48, especially down here in New Mexico. But I have to say I'm not advocating for that. I'm just here to share my information. We're happy with what we have in Alaska. The tribal health system needs that we had were that we needed effective prevention efforts. You know, when you talk about dental disease, it's pretty much a 100% preventable issue. So of course, prevention is the first place we want to go with that. We had, and that's where we went initially with our dental health aides, is we developed primary dental health aides, which are like the ADAs, community oral health practitioners. When they were out in the villages, they kind of sat there twiddling their thumbs because patients weren't coming to see them. We couldn't figure out why, because we're like, well, you should come and hear them. They have good stuff to tell you. The fact is that the patients had a lot of disease that was already existing. They had toothaches. They had holes in their teeth that needed fixing. They didn't want to hear somebody tell them to brush their teeth, especially when that somebody didn't have any magic access to more dentists, because there weren't more dentists. And no more providers that could do those dental procedures. So we moved away from that initial thrust of the prevention-only aspect to our dental health aid therapist program, which combines both some of the more basic needed services a dentist can provide, plus allows for the education process as well. We wanted these providers to be culturally competent and provide culturally competent care. Traditionally in Alaska, dentists have been come up from the lower 48, got their loan repayment after working for about 3 years or so and left. That's not a very efficient way to provide care with a lot of turnover happening, because you know, each time you get somebody new in, it takes a while to get them up to speed. We figured if we had people that were from the communities, going back to the communities, we'd have a chance of having providers stick around a lot longer. We needed them to provide basic restorative services for the reason I already talked about. Locally provided, because you know, people have trouble getting from one place to the other in our state. I think I've heard the same thing happening in your state, even within the same city. And we knew if we would try and meet our needs intelligently, that would lead to more efficiencies. So, thank you. The Alaska solution was our dental health aides. Like I said, I've already talked about 2 of them. We actually have 4 different providers that we introduced through our dental health aid initiative. The primary dental health aides, the DHAS, are the ones I've talked about. We also have expanded function dental health aides, which are expanded function dental assistants. That wasn't in existence in Alaska when we developed the program. We also have dental health aid hygienists to allow the hygienist to be able to provide local anesthesia when the dentist wasn't in the clinic with them, because they'd go out to the villages and try and do scaling and root planing without being able to numb the patients up, and that wasn't very helpful for anybody. So we've added those in. The good news is that since we've done that, the state has changed their Practice Act to allow for expanded function dental assistants and to allow for some expanded functions of dental hygiene, allowing them to do the collaborative type practices where they can do the local anesthetic, or actually they can also do restorative services. All of our dental health aides are supervised by a licensed dentist. Go ahead and change. Scope of practice is here. It's one of the things, I've highlighted a couple of things here. One is diagnosis and treatment planning. I think that's critical. If you're waiting for a dentist to come around and check these patients out and do the diagnosis and treatment planning, you're going to be waiting a long time because they're not out there now. And with a therapist out there, they're surely not going to come out there. They need to have that ability. And anyway, the reality is if any dentist can tell you that as you're prepping a tooth, taking the cavity out and excavating that decay, all through that procedure you have to reevaluate and re-diagnose the tissues that you're working on. If they have no ability to diagnose and treatment plan, then they really are not able to provide the entire procedure of an excavation, and that's a real disservice and a problem of safety for the patient, actually. We included extractions. You know, when you've had a patient population that hasn't had access to care for so long, there are going to be people that need extractions. And the reality is extractions are much more simple to teach than a class 2 amalgam prep. You can do those really simply for the straightforward, simple extractions that are within our scope of practice for dental therapists. So there's no reason not to include it, basically. In our program, we treat all ages. Age is really not a scope of practice. Age is a legislative or practice restriction. You know, if you can treat a patient to the age of 18, that patient already has a full complement of adult teeth. Putting that age limit at 18 is pretty arbitrary when you look at it in that way. We include general supervision, so the dental therapist does not have to be in the same facility as the dentist. That really opens up the ability of that therapist to get out there where the dentist is not and provide services in those areas of real high need. And they're part of a dental team, though. Even though they may not be located in the same area, they're part of a team that's working together with a supervising dentist leading that team. Next. So the new type of provider that we introduced called the dental health aid therapist, a lot of people kind of look at those and think they're a mini dentist. I really believe that they should not be mini dentists. I'm a dentist, and DDS is what I have. That's a doctor of dental surgery. I like to cut things out. That's what we're good at. We spend a lot of time learning how to do that. Improving somebody's oral health is not about just cutting things out. And to put more dentists out there, we've used that model forever and ever, the traditional model of dental practice in the United States, and we're seeing now an increase of decay in almost all populations. So that's not the perfect model. I don't want to replicate this. I want to do something even better. So we really look at developing providers that their primary goal is not about drilling and filling. Their primary goal is about relationships with their native patients. Because we do believe that if they don't have that relationship, then they're never going to get the patients in their chair. And if the patient doesn't come in, there's nothing you can do to work with them on improving their oral health. And patients that are living in communities where you have lack of access have often have had very traumatic experiences because they only get to go in when it's really the worst. They can't stand the pain anymore, and then they have to have these real invasive procedures. They start to understand that dentistry is a really invasive thing that you should be afraid of. It's painful. If we have them coming in earlier and working with us before those things get so out of control, then I think we can start developing a new culture of patients that are not fearful and not avoiding coming to the dentist. So next. Since 2003, when we first sent students to New Zealand for the dental therapy education, we didn't open our program in Alaska until 2007, so had to send them off somewhere else first. Since then, we've had 35 students go through a dental therapy education program, the 2-year post-high school one. 35 have successfully completed. 25 are certified still as of June of this year. And then we had 4 graduate in June, so they're in their preceptorship. That makes 29 providers in the state that did not exist previously to 2003. And in nearly 10 years of practice, we've had a retention rate of 82% of that. Conan Murat out of Naniak has been up there for about 9 years now, doing the same stuff, and he has no intention of leaving. His favorite slogan is, born here, staying here, taking care of my own people. And our graduation rate from our program is about 64%, which is very comparable to undergrad programs around the United States. The systems that we use are really systems that help ensure our success and the safety of our patients. The routine of supervision is something that's ingrained in a dental therapist from the very first day they walk into the educational program. Yesterday was our first day for classes of our 7th class that's coming in, and I talked to them about this specifically that first day, where we said, you're going to be providers that are very different from a dentist. When I went to dental school, I learned as much as I could. I got a license. My license says I can practice general dentistry, the entire scope. Now, you don't want me doing jaw surgery on you. You don't want me doing a crown and bridge even, because I've only done about 5 in my career, being in public health the way I have. So it's up to me personally, my ethical sensibilities, to limit myself as a professional. The dental therapist, however, comes into school with a very different mindset, that they have a limited scope of practice, and they have a supervisor, and the 2 of them will decide what services they'll be providing. So we don't run into issues with our dental therapists going outside their scope. If anything, they really work hard to police each other and watch each other and make sure it doesn't happen, because they understand that from the beginning. Their supervision is solidified through their preceptorship. Once they graduate from our educational program, they go and work on site with their supervising dentist for a number of hours, just 400 hours or 3 months, whichever is longer as a minimum. Usually they take around 6 months. And then that supervision is also maintained in the field. So when I supervised a dental therapist, I had a meeting every morning on the phone with them for about 5 minutes, just to discuss what was going on for the day and things that had come up from the previous day. And then they have the ability to call in at any time during the day if something comes up. We have formats for reports and consultation that have been developed throughout the state that ensure that all the information necessary is being transferred to people during consultations and referrals. We use HIPAA compliance systems, of course. We have these telehealth carts you see on the left side there. And those are really great and fancy and fairly expensive, actually. But they're all HIPAA compliant, and they have everything we need. They've got an intraoral camera, a digital camera. You can scan your X-rays, whatever you need to do. But the reality is, we really don't need that to be able to have effective supervision in our communities. The bulk of our supervision comes from phone calls, the old-fashioned way. So while you can spend a lot of money on that, don't let that scare you away. You don't actually need to. There's ways to work with just phones and internet. So next. So people are always asking me, well, how do you know dentists will be able to supervise these guys? Well, dentists have supervised, as long as I've known about dentistry, they've supervised hygienists and dental assistants, front desk people. They're very successful at that. Dentists are great business and administrators. So I'm not so concerned about that. That's part of what they do. In our system, we really want our supervisors to not only supervise, but to be a good mentor and really think of themselves as a colleague with that dental therapist. They're both considered oral health professionals. There's many different models of how that supervision can work with dental therapists. In New Zealand, we have dentists that work for the state government that supervise any number of dental therapists, as many as maybe 60, some of them, but that's their entire job. Okay, not everybody would supervise that many. In Canada, the typical setup was that one dentist, their job was as a dental therapist supervisor, and they might supervise anywhere from 8 to 10 dental therapists. In Alaska, the most we've had any one dentist supervising is 4, and that was for a very short time, but typically we see about 2 to 3 being supervised at any one point, because our dentists are not just supervising the therapists, they've got a full schedule of their own to work with. Next. Part of this is just a model of how you could work with dental therapists in a system. We have larger clinics with dentists, hygienists, and assistants. They could also have a DHAT there and the primary dental health aides as well. Other smaller clinics may run without a dental therapist there, and we have the dentist from the larger clinic supervising that team. One thing that's nice about our system is that all of our dental health aides work in a community clinic, so they work side by side with the medical providers. So we have a more integrated, holistic approach to the healthcare, which we feel pretty proud about. Next slide. You already heard we've got over 40,000 people now have access to dental care that didn't have it before. Our dental therapists are living and working where dentists have never worked before. There's never been a dentist live in Shishmaref before, but we've got Robert Curtis there living and working. He's been there for 3 years, had a little baby out there. I think he's going to be there for a while. They're staying around and doing a good job, and they become part of the community. And then what we see is that the continuity of care for our patients has really improved. The community now has their own dental provider, and that provider has direct access to the supervising dentist. What we see happening now is the dental therapist takes care of all the basic needs, gets the patient cleaned up, but to a healthy state, so that they're ready for higher level services, and they get to work with them through the educational process to help the patient value those higher level services. So while many of our communities walking around without your front teeth has never been much of a stigma, we're starting to see people who are interested in getting partials, and because the therapists are doing the basic services, the dentists now have time to do things like denture clinics in some of the villages. So they'll have the dental therapist do all that work, get the patients lined up and scheduled, and the dentist will come out for a week, work very efficiently, get all those denture patients worked on, take it back, make those dentures, and then come back another week and deliver them. So it's actually ended up with our patients are accessing higher level and higher quality care than we were before, and I wasn't expecting that, but that's been great. And our dentists have said they're very excited about this because they get to do some things that they were actually trained to do. You know, that's why they spent all of those years more than the dental therapists, so they could learn those higher level, more fun procedures, so they say. We've been studied and studied and studied. This is One Study Research Triangle Institute, very respectable, internationally renowned institute. Looked at our therapists, did a very in-depth study. 5 therapists who had been working the longest in the state, so they could look at longer history of practice. They found they're working safely and appropriately within the defined scope of practice and are technically competent to perform these procedures. They looked at the services provided by a dentist and a therapist under a blinded study, and there was no significant difference between the quality that they observed. And then our patients, they surveyed our patients and found that we have a 95% satisfaction rate. Challenged most of the other providers out there to come up with that high of a satisfaction rate. Next. So one thing I just want to mention, because there's going to be a lot of talk about this, I'm sure there already has been in your state, is how much dental therapy education is enough. Historically, in around the world, it's been 2 years without any prerequisites. There are 3-year programs that are developing for dually qualified hygienists and therapists around the world. The reason they're doing that is because there have not been hygienists in many other countries. Hygiene is the dental hygienist is a U.S. creation, and so they have a need and a lack of that service provider in their countries. So they're adding an additional year and coming out with a dual degree. In the U.S., we have lots of hygienists, so the need to make it strictly a dual degree program here is not, in my mind, so urgent. I hear a lot of people talking about, oh, we'll just have the hygienists go through 1 more year and they'll be able to do the whole scope of dental therapy. I don't believe it can be done in 1 year, simply because the skill set that's needed is so different than the hygiene skill set. I think it just takes more time practicing those procedures than you would get in just 1 year. And you heard Colleen talk about her program is 28 months, and she actually started with less, but had to end it. Told me she had to add additional time so that they would have more time to practice those services. 1 2-year program, though, I think could actually answer all of those questions. I don't think you have to talk about either or. I think that if you had a 2-year program for dental therapy in which you had a flexible admission process with waivers allowed, the hygienists could be waived out of those courses that they've already taken through their hygiene program, but they'd also be able to go through the course and have the time to develop those new skill sets that come with the dental therapy scope. and get those down over the time. What Colleen said at the end of her talk was that her hygienist really value being able to go not completely full-time all 2 years, so that they have time to go out and work and make a living at the same time that they're in school, especially if you've got older hygienists that are coming back into a program. I think that, and that are used to making a salary, they're going to want to have that ability, and having that flexible 2-year program where you have the ability for the hygienist to waive some of those courses, they'll have the time then to go and work part-time at the same time. So I really think if we just think about it differently, stop talking about either or, that we can develop one program to meet everybody's needs. Who are your target students? That's really important. Education and access are basic human rights. And we have gone in this country back to the elitist attitude about education. And we're making it unattainable for many parts of our population. Requiring a bachelor's degree would make health careers inaccessible to many people, said one of the deans of an allied health and nursing program in Kentucky. You know, sometimes they just need to take a chunk at a time and have a career path. Next slide. Another president of a community college down in Arkansas said that additional problems with degree creep in nursing, a lack of qualified faculty to teach. You know, you require a bachelor's degree now, and a lot of your nurses out there are AA degrees. So where are you going to get your faculty to teach those bachelors? A decline in workforce diversity. The more education that's required, the less diversity in the population of students. It's been documented in many different areas of education. A decrease in access to healthcare for rural areas. So more education, the less likely those providers are to go out to the rural communities and work. And a decline in job satisfaction and morale if the healthcare workers feel their skills and knowledge are not fully being utilized. So, and I've heard this from some hygienists that, you know, they've got a master's degree and they're still only allowed that same scope that an associate degree hygienist. That's not very satisfying. Those hygienists have this knowledge set to be able to do a lot more than what they're being allowed to do. So too much education is not necessarily better. Enough is enough, and that's what we need to aim for. This is just my contact information.
Does folks have any questions for Mary about the program, dental therapist working in Alaska, or any more questions about sort of details around the education process?
Mary, you may have said this, and I apologize, I was out of the room. Are these all public health dentists that are supervising dentists, or are there any private dentists in this program?
In our system, it's run in only in the tribal health system. So all of the dentists that supervise are either U.S. public health dentists or they're direct hires of a tribal health organization. They are not private practitioners.
Okay. And my next question is to the business model. Mm-hmm. And this discussion has come up before about salary, a dental hygienist, and what he or she has invested into their education to be a dental hygienist. And now they go back for 24 months to become a dental therapist. Mm-hmm. Do you have a recommendation or any ideas on what is the business model? What kind of compensation is a dental therapist expecting versus what a dental hygienist?
Mm-hmm. Well, I don't have any experience with the dually qualified therapist. What we pay or recommend the corporations pay their dental therapists who are starting out is half of what a dentist would make in their starting salary. Okay. It would make sense to me that if you had somebody that had the hygiene scope, that they would have an additional pay level. How much more? I really don't know what the market will hold. Right now, our dental therapists are making a little bit less than the hygienist anyway in our system.
Thank you.
In Minnesota, just to add some context, the graduates of Colleen's program are making on average about $45 an hour, and the graduates of the University of Minnesota dental therapy program are making around 40. So, but in terms of the viability, because some are working for private practice dentists, they're seeing 29, as Pamela referenced, in Minnesota, you have to see at least 50% Medicaid patients as far as the patient load of the dental therapist. And for every dollar they generate, it costs 29 cents to employ them for the cost of employing the dental therapist, the salary and benefits. And in Alaska, it's 27%. So they're very similar in terms of the cost of employing dental therapists in both systems. So as much as folks would like to frame things as Alaska being an outlier, it just shows how the cost of employing and deploying dental therapists is very similar when you actually look at the practice models and across a lot of different practice models that were studied in the report that we did. So very economically viable. Any other questions for?
Can I just make a comment? I think it's really interesting to look at Mary's program versus the complexities of the programs in Minnesota. And you know, there are two types of classes that are produced and requirements that result. Ones that you need to gain knowledge so that you can do the job, and requirements that are there so that you can actually protect the public so that people are competent. Then you have others that are barriers to entry to the profession that are put in there. You know, degree creep is, there are things that are added by creeps with degrees. I mean, I think people who have a lot of degrees and don't want other people to, you know, get into their profession too rapidly, I think you see those complications when you look at other programs. So I hope y'all can, you know, I think Mary's program is closest to the kind that can, one, provide the greatest help to people the quickest, and secondly, provide an entry into the profession for local people who are most likely to stay and benefit the places that they grew up.
Any other questions for Mary in terms of?
Mary, how long is your program? How many credit hours?
We don't do credit hours really.
Okay.
We're not we're run by a health corporation, not an institute of an accredited higher education institution. We have over 3,000 hours though contact hours with the students. They're in class for 8 to 5, Monday through Friday, for most of the year. They get off about 2 months in the summers.
So that's something, I was going to say, that's something kind of a difference in where we're trying to stay away from length, because this is an intensive program that gets someone in and out efficiently doing the quality services. Now Minnesota, I think some of their student population had a need of doing more part-time. But this is a really good way to really get people providing services, actually not just in school, but a little bit more rapidly as well. So, and that we want schools to have that kind of flexibility to know that's feasible for them to work with.
Yeah, and half of those hours pretty much are actually direct patient care.
Could you actually, I actually think that's a couple of points just to drive, I guess, very quickly the breakdown in terms of like preclinical, clinical of the program, but also I think if you could describe sort of the second year in Bethel in terms of where you were going with the clinical care and how much direct interaction.
Yeah, my mind is not working like it should today, so I have to look up your breakdown. I have it right here. So there's a total of 79 weeks in our program, 40 in the first year and 39 in the second. In the first year, it's 30% basic sciences, 10% social sciences, and 40% preclinical, and about 20% of clinical, seeing patients. In the second year, it goes to where we're doing about 15% of biological sciences, 7% is social sciences. There's not really any significant preclinical work. And 78% of their time in that second year is spent with clinical. So they end up with a very clinically heavy clinical experience, and that's one of the things that our supervisors talk about is when they get the therapists out, the therapists really can do their scope of practice. I've had a supervisor from down in Southeast Regional Health Corporation that said, you know, I'm so much more comfortable letting a dental therapist go see a patient when they first come to us out of school than I am with dentists, because the dentists don't know their limits and they don't and they haven't had enough practice on actual patients in each of those procedures. The therapists are much more competent by the time they get out.
Well, I think it's interesting. I've been to Alaska several times, obviously, and I've looked at the amount and talked to Mary about the amount of pediatric dentistry that the dental therapists do, and I compared that to what they do at the University of Colorado in the dental pre-doctoral program dental students do. And they do much more as dental therapists than the dental students, many of whom who come to New Mexico, do when they're going to dental school. So I think it's clear to say that a dental therapist is probably more competent in treating kids than a dental student graduate from the University of Colorado, because they just don't get enough time to do it.
Yeah, a lot of them are now, when they get a new dental school graduate, they have them sort of shadow the dental therapist to teach them how to work with kids better.
I have a quick question. Forgive me if I have the numbers incorrect. I think you said 35 students completed the program and 25 are practicing. Do you know what factors played into those that are no longer practicing?
Actually, 29 are practicing. Just 4 of them haven't gotten certified yet because they just graduated. Yeah, there's lots of different reasons. There's a couple of women that had babies and their babies were getting up into school age and they wanted them to go into larger cities for better schools. Some had a husband that needed to move for work and they decided to go with them, and it was to a community that doesn't have a dental therapy program. We've had people decide to go do different things. One of our dental therapists is getting trained as a community health aide to learn the medical aspect of it. And had one die, unfortunately. And then there have been a couple that their personal lives got in the way of their professional aspirations.
So most of it's all personal, not systematic or programmatic?
No. You know, and even the ones that, some of the ones that are not certified anymore that had personal issues, that they've tried to clean themselves up and come back, they do want to come back usually. Yeah.
Mary, what do they have to do to remain certified?
Every 2 years they get recertified, and to get recertified they have to show that they are still competent in their entire scope of practice as a dental therapist to their supervising dentist, and the supervising dentist has to certify that. In the past we've had that they have to perform 8 of each of those different services within their scope under direct supervision where the dentist is watching. We're changing that because our supervisor's like, I don't have to watch them do 8 fluoride applications to know they can do that. So we're giving the dental supervisor a little more leeway and taking out the number and just saying, you know, you need to be able to certify they're competent in the entire scope. And you have to directly observe them for at least 80 hours every 2 years. Plus they have the same requirements of continuing education as dentists do in the state.
My question is also about your kind of the selection of the students, but more than that, supporting these students. They've come from underserved areas, probably communities not unlike New Mexico, where the educational achievement is not certainly where we want it to be. how do you help to support them, whether it's, I guess it would be academically or otherwise? I think you have some unique structures. Like maybe they all study, I think they all study together as a cohort. They go to school together. There's a team.
Mm-hmm, right. Yeah, we do a lot to keep students in school. Our dropout rate for high school students is huge, and I hear you have a massive problem with that here as well. So that's the culture that we bring students in from. And anytime you have a place, you know, a community that has access to care issues for health care, they've got access to services issues, for social services, mental health services. A lot of times the communities are suffering from the effects of domestic violence and abuse and things, and substance abuse. So we have all of that too in a lot of the communities where we recruit our students from. And one of the things that I ended up doing in the first few years running this program was counseling students all the time. And I'm like, I am not a counselor. I'm not a psychologist. I've seen a psychologist enough. I should have a degree. But yeah, but I don't have that qualification, and it's big stuff. So I developed a course called Healing the Healer, I call it, and it's part of their professional role development program, where we bring in a psychologist every 2 weeks in the first year to meet with this class as a group. And they talk about things like developing boundaries, personal boundaries, talk about substance abuse and domestic violence, all of those really tough things that our students have either experienced or seen in their families, and definitely will have patients sit in their chairs that have those experiences. So, you know, whether they're suffering from those burdens or whether they are at threat for being burned out as a provider in the middle of a community with these issues, they need to have the skills involved to be able to survive. We have a huge issue of provider burnout up in Alaska, and that's a lot of why we have such a turnout rate. So basically we're teaching resiliency more than anything, and that comes back to that adverse childhood experiences information training that's going on these days. So giving them that information so that they can be more successful is really important. What other things were you talking about?
I think part of their training, I think they're in Anchorage first, and they kind of all live together the first year, and then the second year they go to Bethel.
Yeah, so like she said, it was really an intensive course when they're in there, you know, 8 hours a day with each other. Well, most of them actually go back and live in the same area as well. So, and being a smaller program, we have the ability to work a little differently. So we really encourage them to work together and study groups and support each other in lots of different ways. So we don't have that issue where we had in dental school. You know, everybody was out for their own good and you know, didn't share their information with you. We really have a very different feeling in the school, and we talk about ourselves as the DHAT family, and welcome in all of their family members to that family, and it does feel that way. It seems to benefit everybody.
Jerry?
I got a chance to visit your program with David a few years ago, and excuse me for coming in late because you may have already addressed this.
Do you want to introduce yourself?
I'm Jerry Harrison. I'm Executive Director of New Mexico Health Resources. I recruit dentists away from Alaska and bring so we want the DHAT program to be successful. I wander around to dental schools, attend the UNM Pre-Dental Society meetings, and there's a tremendous emphasis upon DAT scores and GPA. And as I vaguely recall from our meeting with you in Anchorage, or maybe even in Bethel, that there were positive things in terms of selecting participants in the program. Any of those come to mind? Because they really made an impression upon us when we visited with you, that there was an attempt to assure success. And I think our folks who might be considering programs that are in public institutions would have some questions about who do you select to participate.
Yeah, we don't have a GPA. Our requirements are that they have a high school diploma or a GED and be 18 years old by the time they start seeing patients. They have a drug test and background check as well, but those are really it. The whole of the community health aid program, which has been up in Alaska for 50 years, the educational program is built on, they have to have at least a 6th grade education, reading level and comprehension. So we've built our program around that benchmark. Again, going back to the communities and their school systems are suffering as well for teachers, and so we do a lot to work with the students. We some of our students are English as a second language, which you'll find, I'm sure, in your communities. So in their first year, we do things that you might think, why are you bothering with this? We'll have them read classic literature, and they'll have to just tell us what the plot is. And so we do sort of a mini English written language course for them, but we make it fun and interesting. We try to pick Native American themed literature as well. And eventually we get them to the point where they're actually writing a SOAPy note, which is the note format we have for our patient notes, encounter notes, on these short stories that they're reading. So we get them to start being able to do the communication that's required of somebody who's working as a supervised provider and having to do referrals and things like that. And then we also have them do a lot of research on the internet to teach them how to be lifelong learners.
Many of your, the dental therapists, I imagine, both in Minnesota and from Alaska, most of them aren't just freshly out of high school, is what I understand. They've had other jobs, or they're adults who they just want to do something else. They want a pathway or a career opportunity. Is that accurate, or? Yeah,
we get all different ranges. I think it's been from 18 to 52 or something like that, the student range. One of the big wonderful things about our program is this is a career path that they can have a well-paying position in the village. When they go back, they're pretty much one of the highest paid people in that community. They're also getting involved in the community in many different ways. So really and I told them this yesterday, the least important thing you'll be doing is dentistry. The most important thing you're going to be doing is being a role model in your community and being an agent for change in your community. You will have the skills that many of your other community members won't have. You could be on your tribal council, you could be on your school board, you could volunteer at different things. And so we teach them a little bit about how to do that as well.
Mary, I just want to add to what you just said in regard to when I was there. I remember basically my impression was that the students see a need from their communities and they want to do something to help their communities, and I think that's how they get involved in this program.
Yeah, and I can't express that as well as our students can, because it really does come from their heart that this is their family members and their extended family that they're talking about that need the services, and they've experienced this themselves. They want better for their communities and their children, and it's really heartfelt. And a lot of them are actually sort of picked by the community to go to this program and come back and serve their people.
So do you turn students away, applicants away? I mean, if you have so many that you take, is there a greater need?
Every year we get more and more applicants. Our system is a little odd in that because we're not in an institution, an accredited higher education institution, our students can't get financial aid to come to the program, so they're all sponsored by a health corporation who pays their tuition. And they have an educational loan agreement with that health organization, 2 years of education for 4 years of service when they graduate. And they get paid during that time. So then the health corporations do the initial interviews. And so I don't have the exact numbers of how many people the health corporations interview. And then they send us their best candidates, and they tell us how many students they're willing to support or they have the finances to support through it. And so we pick from those slimmed down pool of applicants. I've been told from one organization, the largest one, that they had 40 applicants for 4 positions last year.
So, just to clarify, so when Jerry had asked you, so you guys have a certain baseline, but before you have your students, they've sort of been identified by the health corporation. It's a competitive process, and I think a lot of them you've said to me before, and I don't know if it's fair to say, that they're really identified as potential leaders for their community. Mm-hmm. So it is a pretty competitive process, and there's a lot of vetting that goes through. So I think, and I know from talking to panelists, it's sort of like some input maybe from the corporations and for you further, sort of like how do you identify these community leaders in New Mexico that can sort of have those leadership qualities that are going to go back and take that mantle.
Yeah, you have a community with that's invested in this person, and that means a lot, and it motivates certain people to do, really work hard at it.
Any more questions for Mary? Why don't we take
Just one question. Do you give them grades or just credits? Or just you just keep track of the hours?
We do give them grades, and they actually get credit for the some of the courses they do in the first year through the University of Washington, who we contract with. So they get some credits that way, and those can be transferable to, we've seen students transfer that to UAA. I'm working with UAA to try and get credits for the entire program. We'll see what we can have happen there. And we give them grades. In the first year, we give them grades just like the University of Washington does for all of their students. In the second year, we go more with pass-fail, although they have, stratified clinical evaluations that they get on every patient. But really, we're talking about competency-based work here, and A, B, and C isn't what we're really after. We're after, are you competent? Are you competent to perform this with the supervisor right next to you, or are you more capable of doing this mostly on your own with just the supervisor checking in with you? So we do, in the second year, they have an interview every quarter with the Student Progress Committee, and they get a letter that tells them whether they're meeting expectations, not meeting expectations, requiring remediation in any area, and then it describes what they have to do to continue.